সম্ভব হয় আপনি দরকার হলে কাউকে একটু E9-এর সামনে পাঠান আপনার বাসায় আনার জন্য। হ্যাঁ E9-এ, হ্যাঁ 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 এক মিনিট, হ্যাঁ আচ্ছা।
এই গ্যাপে ব্যাচ ওয়াইজ গিয়ে ছবি তুলে নেন সঙ্গে, বুঝছেন? পরে খালি সুযোগ পাবেন না। তবে মাসুম বোধহয় রাখেন নাই না, ফটো তোলার কর্নার রাখেন নাই। হ্যাঁ টাকা দিব না, ম্যানেজারের বাড়িতে রাখেন। প্রিপারেশন নিচ্ছি স্যার পরে না স্যার আমি পরে স্যার পরে
মাসুম ভাই,
এটা তো আছে
respect to the overall population in our country, perception that the pandemic disrupted life events, affected mental health, jobs, economy, education, and the prediction of an worsening situation which we are observing at the moment. I don't know, we can call today as the second wave of COVID or third wave, but we are actually observing the worsening situation which our population have predicted last year, and uncertainty of the healthcare system's capacities. We are struggling with limited number of ICUs. Everything is creating impact on mental health. I definitely want to acknowledge to the fact that it's very difficult to say like all these things are happening. These mental health, symptoms are happening because of COVID, but we can definitely say like during the pandemic, these symptoms are happening and we are observing the toll of mental health. So the objective of this particular study was to explore the impact of COVID-19 on mental health among registered Bangladeshi physicians. So registered means BMDC registered physicians, those were residing in the country during the pandemic. We did a cross-sectional study and we followed both convenience and snowball sampling recruited via social media. So it was an online survey to be more precise, and we collected data over a 3 weeks time. It happened in the initial lockdown period, 21st April 2020 to 10th May 2020. So you only have included, I already mentioned, like BMDC registered physicians, dental and MBBS.
Welcome everyone after the lunch break. Dear audience, scientific session will start now. It's our pleasure to introduce Dr. Ali Akbar Ashrafi, moderator of this session. He has vast experience in government health services at every level of the system. Dr. Ali Akbar Ashrafi is now working as Chief Health Information Unit, Management Information System, Director General of Health Service. Dr. Mollik Masum Billah, Senior Scientific Officer, Department of Epidemiology, and Dr. Farsi, Medical Officer, IEDCR, are organizing this session. Both of them are FETPB graduates. Along with them, Dr. Salihin, Dr. Jafrin, and Dr. Nobi will facilitate the online activities. Now I request our respected moderator to conduct this scientific session. Thank you, sir.
Thank you. Thank you. Welcome to all. After the lunch, this session, especially for those who are working on the COVID-19 pandemic situations for the containment and other activities. So, first of all, I request Dr. Nisarga Mira Chaudhary. He is working as a Upazila Health and Family Planning Officer, Manoharganj, District Kumilla of Chittagong Chattogram Division, Bangladesh. Right now, he is working as a District Coordinator, COVID Cell, Kumilla Civil Surgeon Office. He is one of the member of the FETP Cohort 3, third cohort. Basically, he is working, he will present implementation of zoning system that improve the COVID-19 situation after the Eid vacation in Kumilla district in 2020. Basically, you know that during the Eid vacation, there is a huge movement of the citizen of Bangladesh from one district to another district. So he will present on the implementation of the zoning at that time. Thank you, and thanks to Ms. Dr. Nisarga Mira Chaudhary.
Thank you, the moderator, sir. The respected audience, I welcome you all in my presentation. I am Dr. Nisarga Mira Chaudhary, UHFPO Manoharganj, and FETP Advanced Third Cohort. So, sorry to say that my title is changed, and it is the title of Zoning System. Zoning System Reduce COVID-19 Transmission Kumilla, Bangladesh 2020. Okay. Sorry for the interventions. Respected audience, I welcome you all in my presentation, that is a Zoning System Reduce COVID-19 Transmission Kumilla, Bangladesh 2020. I am Dr. Nisarga Mira Chaudhary, UHFPO Manoharganj, and FETP Advanced Graduate, third cohort. So, as we all know that the novel coronavirus outbreak began in December 9, 2019 in Wuhan, China. From there, the infection spread worldwide. It infected in America, in Europe, in Brazil, and African country, as well as the South Asia, where the Bangladesh is also infected. We identified our first case on 8 March 2020. In Kumilla district, we identified our first case on 7th April 2020. Kumilla became the hotspot for the COVID-19 after the first Eid vacation, that is the Eid al-Fitr on 25th May. Therefore, the district Corona Prevention Committee implemented the red zone system in the district, that is in 20th June, it is for the 2 months. On the second Eid vacation, the Eid ul-Adha, that is a public holiday, the number of cases decreased. So this picture is showing that how we implemented the scenario of the lockdown situation. This is the center point of the Kumilla City Corporation. This is the Kandirpar area where there is no any movement is visible and it's maintained. And the second picture showing that the police are deployed in the roads and everywhere to maintain the lockdown situation. So the objective of this study is to compare the COVID-19 scenario before and after the implementation of zoning system between the 2 Eid vacations. The method is there, it's a cross-sectional study, and the study is happened in Kumilla district, which is a populated 62 million people. And the period of the study is the 14 days before and after the Eid ul-Fitr on 25th May, and 14 days before and after the Eid ul-Adha in the 1st August. So we identified our corona positive cases as those patients who are RT-PCR positive. The data were collected from the district civil surgeon office contact tracing form, and the zoning system is implemented for the 20th June to 31st August. And we, according to the national guideline and IDCR, we followed the process of red zoning, and then we identified the red zone unit as the 15 cases per union or ward level, and 5 to 6 red zone from the red zone area. And when we identified this red zone area, we plotted in the map, that is the spot map. This picture is showing that how we plotted these red zones manually in our office, and this is how we identified the risk zone in Kumilla district. So the restrictions during the Eid, which is means that the strict lockdown from June 20th to August 31st. Then in that time, the marketplaces were closed except the essential shop within the time limit. People were asked to remain self-quarantine. All office, school remain closed. The movement restriction is implemented like no vehicle allowed except the emergency transport. No one allowed in the street without mask. Selected person per family allowed to go for shop, and social awareness was programmed everywhere. This picture shows that the army was deployed in the streets, and they actually monitoring the movement restriction, also help the people to get their goods in on time when it is needed. So I'm come to my result section. So the gender distribution of the cases 14 days before and after the Eid vacations in Kumilla, we identified 2,844 cases. That is 71.5% are male and 28.5% are female. And according to the age distribution, we found that the 31 to 40 years of age group is the majority of the cases from that group. It's a 28.8%. And the second highest is the 21 to 30 years of age. That means the 20 to 40 years is the most vulnerable group for get infected. This is the line chart which is showing that the timeline when it is implemented. The Eid ul-Fitr is the 25th May. The cases rised, and then we implemented the red zone on 20th June. And then after the Eid ul-Adha, which is the 1st August, the cases became decreased on, and later on we found that the cases were declining, and then we closed the red zoning system. So this spot map showing there is I'm sorry for the mapping, map is not so much clear. Though we identified 15 red zone areas in Kumilla district, and therefore we implemented our red zone lockdown system in that places. So this is an upazila-wise distribution of the cases. If you see the numbers, like before the Eid ul-Fitr, the cases were not much increased, but after the Eid ul-Fitr, when the first Eid vacation, the cases were raised in Choddogram like 10 to 15 fold, like which is an 11 number before Eid, it became 154. In the Kumilla City Corporation, it was 84, and after the Eid, it became 351. And it is followed in everywhere, the cases were increased, except in Muradnagar, because Muradnagar is the upazila which is the first area of hotspot. So we have implemented our basic public health measures there for early prevention. Therefore, maybe it shows that the cases decline after the Eid al-Fitr. And this is the snapshot of the whole scenario. Like everywhere, we have seen the rise of the case after the Eid al-Fitr, except Muradnagar and Nangolkot. And this is the scenario during the Eid al-Azha, before and after the Eid al-Azha. Like after Eid al-Azha, previously we have identified 15 red spots, but when the red zone is implemented, we restrict the areas, we implemented the lockdown. Then the hotspot area became 6. That means we got the improvement. And in Upazila-wise distribution, like in the city corporation, as you know, the city corporation is a very populated area. So before the Eid al-Azha, that is the 290 case, but after the Eid, it became 283. Though the number is very similar, but it shows that we are capable to decrease the numbers. So this is the snapshot of the whole upazilas when we see that before the Eid, the cases were decreased after the Eid vacation. So we have some limitations, like we count the cases from those who were tested, but not the everyone. So it may be not the clear picture of the COVID situation, but it's those who are tested, we count them. And we actually can't conclude like for the red zoning system, it is actually declined. Maybe there is a seasonal variation or anything, but we cannot exclude that things. So my conclusion is the implementation of a red zone zoning system reduce the transmission of COVID-19, and the zoning can be useful community intervention to prevent the rapid spread of infection. So thank you. Thanks for your kind patience hearing.
Thank you. Thank you, Dr. Nisarga Mira Chaudhary, for your nice presentation. So there is a question in the chat box. Being a sub-district level manager, what hindrance did you face to contain COVID in your Upazila? That is in the Manoharganj.
Yes. Thank you, sir. Thank you for the questions. Actually, in the sub-district level, it is very challenging for the district, the health managers, because one challenge is the awareness. Like people are not aware about their situation. They don't want to follow the rules. They don't want to follow what we are saying, the public health measures like hand wash, wearing mask. They don't care about it. So it's a preliminary challenge for us. And as the pandemic is very new for everyone, and also for the villagers, so motivate them to wear masks, to follow the public health measures is very challenging for us. But we did some local areas, we involved the administrations, we involved the local politicians. That's how the Upazila is fighting for the COVID. Thank you, sir.
Okay. Thank you. So there's another question. Was there any asymptomatic cases being tested?
Yeah, thank you, sir. For the preliminary stage, when we have started our zoning, the counting, we have the asymptomatic cases. Like we did the contact tracing, and when a case found with their family members are involved, we did the sampling, and maybe there is an asymptomatic case. So we include the asymptomatic cases also.
Okay. And another one, there is any active case search at that time?
Every contact tracing is an acute case search. So we go for everywhere when we found the cases.
So there is no other question. So any question from our, okay, please.
Thank you, Dr. Nisarga Mira Chaudhary. It was very nice and interactive presentation. I just want to know from you that you showed a line graph there. After implementing the red zone, we can see a big peak there. Yes. So what do you think? It is an outbreak or any other cause of that peak?
Thank you. Thanks for these nice questions. It's a very interesting area. Like during that period, we know that we have lab capacity is very limited. So Kumilla was started their RT-PCR in Kumilla lab. So in that time, in the June first week and second week, we see that the cases were raised. So then we take the sample from the labs and we identified that the lab is contaminated. In that time, the peak was happened. So it was also reported in IDCR about that situation. That's why the peak is here. Thank you.
So please.
Thank you for your nice presentation. You showed the zone, 15 zone, and all of them are the Upazila. But my question is, you take whole Upazila or partial portion of the Upazila?
Part of the
For your zoning.
Thank you. It's not about the Upazilas, it's about the Kumila district, and we take the whole district. And 15 places in different areas of the district, like it include 1 or 2 spots in one Upazila, and maybe there is some Upazilas, there is no any red zones. So we include all the district, and we not partially, it's cover all the areas of district. Thank you.
Thank you. Is there any question from the audience? Okay. Thank you,
Thank you.
Dr.
Thank you, sir.
Nishar Gomira Chaudhary, for his nice presentation as well as question and answer session.
Thank you, sir.
Thanks a lot. So now I request Major Dr. Muhammad Farooq Ahmed. He is a fellow of FETP's cohort 6 for Uttar Tolarbagh model, a localized community approach for containment of COVID-19 in Dhaka city, especially Dhaka North City in Bangladesh during March to May 2020. So Major Farooq Ahmed.
You're going to pause, please. Respected moderator, other audience present, Assalamu alaikum and good afternoon to you all. Welcome to my presentation on Uttar Tolarbagh model, a localized community approach for containment of COVID-19 in Dhaka city, Bangladesh, March to May 2020. On 8 March 2020, first COVID-19 case found in Bangladesh. Schools were closed on 17 March 2020. General government holidays started from 26 March 2020 that extended up to 30 May 2020. On 20 March 2020, first COVID-19 positive case found in Uttar Tolarbagh, Dhaka, and died on same day. Outbreak investigation team of 2 FETB fellows, 1 anthropologist, 2 medical technologists formed on 20 March. Uttar Tolarbagh is 2 square kilometers walled-in area of Dhaka city with 2 entrance gates. Only 1 road passes through this. Rupali Bank slum is within this area. Figure shows resident building of first positive case of Uttar Tolarbagh, which gone under lockdown on 20 March 2020. On 22 March, another COVID-19 positive case died. On 23 March, localized community containment approach applied by road barrier. Figure shows main gate of Uttar Tolarbagh used as road barrier. Objectives of this study is to find out whether localized containment approach stop COVID-19 transmission or not. My study type was the interventional study. Place is Uttar Tolarbagh, Dhaka, and study period was from 20 March to 30 May 2020. Upon recommendation from the investigation team, closed the 2 entrance gates and restricted non-residents from entering the community. Entry and exit points were guarded by police and security guards. Prohibited entering of any hawker other than approved mobile fresh vegetable seller van, mobile fish seller van, mobile chicken and meat seller van. During intervention period, COVID-19 case identified by contact tracing. Samples of symptomatic contacts collected by COVID-19 testing booth in Uttar Tolarbagh. Samples of symptomatic peoples by active search by going every apartment in the community also collected in this period, while reporting of symptomatic contacts decreased. During post-intervention period, symptomatic peoples reported through hotline from the community for sample collection. Member of Parliament of Dhaka 14 supplied PP, adequate hand sanitizer and disinfectant spray machine to security guard and cleaner of this community. He also provided daily necessities like rice, lentils, potatoes, snacks and coffee packs to the people of the adjacent slum. Religious teacher of Masjidul Ahsan of Uttar Tolarbagh ensures social distancing during routine prayer in mosque, as investigation team found common source of contact place of first 2 cases in that mosque. Leader of Rupali Bank slum provides information about general condition of households of that slum and maintain thermal scanning at pocket gate of slum. For any urgent communication with investigation team, organizing secretary and security secretary of Uttar Tolarbagh House and Flat Owner Association were responsible for coordination. Investigation team coordinated with Kuwait Bangladesh Friendship Government Hospital for positive case evacuation by ambulance for severe symptomatic cases and comorbid cases. Home isolation advised for mild symptomatic cases. COVID-19 case definition was any person tested positive for RT-PCR for COVID-19 at Uttar Tolarbagh, Dhaka from 20 March to 30 May 2020. COVID-19 contact definition was any person who came within 1 meter of COVID-19 confirmed case for 15 minutes or more than 15 minutes before 2 days developed their symptoms, and up to 14 days after without personal protective measure was defined as a contact. Criteria for COVID-19 testing was any person of Uttar Tolarbagh that developed fever, cough or sore throat or respiratory distress was tested within 24 hours for COVID-19 in virology laboratory of IDCR from March 20 to May 30, 2020. Weekly positivity rate was calculated by dividing positive samples in a week by total number of samples tested in that week. Figure shows during intervention, percentage of COVID-19 positive tests are reducing and no case found after 10 April to 30 May 2020 in Uttar Tolarbagh, Bangladesh. Findings suggested localized community containment approach reduced COVID-19 transmission in a community. The Ministry of Health and Family Welfare of Bangladesh identified the approach in Uttar Tolarbagh as a model and later developed a localized containment approach of red, yellow and green zones based on the rate of active cases in the community. Recommendation is to conduct a qualitative study in the population of containment areas to find out the acceptance of the approach in the population. I like to acknowledge for this study Institute of Epidemiology, Disease Control and Research, Director General of Health Services, Field Epidemiology Training Program Bangladesh, Dhaka North City Corporation Office, Civil Surgeon Office Dhaka, Dhaka Range Police and local volunteers. Thank you.
Thank you, Major Farooq. Major Farooq Ahmed. So there is a few questions in the chat box. So at that time, basically, we observed the situation of the Tolarba from the media.
Sir.
As because we are at the house at that time, at the home. So, and we were watched the TV and observing the situation of the Tolarba and the administration, what steps they have taken. So as you mentioned, the first two cases common contact place was mosque at the time. And what are the steps you followed for control measure to lessen the spread?
Actually, we could not stop to say prayer in the mosque, as it is a very sensitive issue. We actually first instructed and discouraged the older people of this community to come in mosque for routine prayer. And we instructed them for routine prayer, they can say their prayer in their residence. And for younger people, they can come with proper protective measure and maintaining the distance according to Islamic foundation.
Yeah. At that time, the Ministry of Religion, they issued a circular and limited the number of how many people will be allowed for the mosque. Probably the 5 people, including the imam.
Yeah, for Jamaat.
For the Jamaat. Right, so they issued a criteria for the Jamaat. So there is another question, that what are the intervention imposed to the community of the Tolarbak at that time?
Actually, there are many interventions. I already stated and mentioned. For food supply, there were volunteers and also reliefs from the member of parliament. And in the mosque, there is social distancing. I have already said, and there was in main gate. In main gate, there was security guard. Those were maintaining the entry point, and there I said already that there were 2 gates, one main gate and another one is second gate. Second gate was permanently blocked.
Yes.
That's how we can maintain the entry point very strictly.
Thank you. And at that time, the entrance and exit was strictly prohibited at that time.
Yeah.
And that we watched from the TV. So, is it applicable to another community?
Actually, I was a bit lucky that there was already 2 gates there. So, and warden area. If I see that there was no gate like that, I can use barrier like bamboo or fence like this. I can use this in different community also.
Okay. So, can you comment that the Tolarbak approach can be implemented now? Right now, the situation of Dhaka or Bangladesh.
I cannot understand, please.
So, can you comment and that the Tolarbak approach can be implemented right now?
It is actually not for long term. I think as it is a airdroplet like infection. So in different countries, we see that that type of localized containment is very successful. So we can contain for a short time. If there was many cases and we can see the cluster in a short place, in a smaller place, then we can approach this type of intervention.
Okay. Thank you. Total, how many cases died in the Uttar Tolarbak during your study? Were they comorbid?
Total 2 cases died, and both of them were comorbid. One have ischemic heart disease with diabetes mellitus, and another one is older aged.
Okay. And so, lot of questions, as because it is the first time in lockdown situation in Dhaka North City. So, what was the criteria for discharge? Those were isolated in the hospital at that time, and no, it changed. So, why Tolarbagh approach differs from other community containment measures?
Actually, it was the first containment approach. I actually didn't know that it could be a containment approach. I went to the community for outbreak investigation. When I see that there was more cases, then we have to strict for containment of 40 buildings of this area.
Oh. And okay. And how testing was maintained in that area?
Testing was maintained up to 12 April. The booth was were there when up to when that positive case were there. Then when you came back from the community, we followed up to after the intervention period. Up to the intervention period, our booth was there 24 hours.
Okay.
And after intervention period, in post-intervention period, we have hotlines, event-based surveillance system. That's how the local people, through their leaders, or they can communicate with us for their sickness, for any investigation, for sample collection.
Okay. And then last one, that is the what would be the home taking message from the Tolarbagh approach? That is the
actually, I want to say that everyone should participate in a localized containment approach, because in containment there are more struggling things came, that no one can go to the office, no one can go to the grocery store. Inside the community, those are the source of grocery store. They can use the grocery store as a queue, and in pharmacy they can use the pharmacy as a queue.
And maintain the physical
distancing. And no one. There was also some messages about the community people that there was on road, so no one can gather on the road by exiting from their apartment. That they are gathering like in the afternoon.
Or gossiping.
It was totally prohibited by security guards.
So, any question from the?
Thank you very much. I'm Dr. Selim from IDCR. It was a pleasure to learn a lot about this containment. So my question is, do you think involving the local community and engaging them in your activities or replicating the same system and engaging the community will make this effort very successful? And if you say yes, how?
Actually, everyone should, it is named as community containment. So I think everyone has his own responsibilities. Like their religious teacher, he take the responsibilities before every azan. He said that do not come older people, only come younger people for Jamaat. Like this, like a member of parliament, he supplied adequate relief. Like every building, every apartment, there were president and secretary. They maintained strictly their own resident gate by security guard. Those who needs anything, by security guard, they take the things from the grocery store or any pharmacy, by mobile fish seller van, anything. Security guards that time, they do really great things, I think.
Okay, another two. So from the chat box, then later on. As you stated that there are the two gates for the entrance and exit. What are the difficulty you faced for blocking the entry gate?
I faced difficulty in for certain times actually, from 23rd March to 26 March. because after 26 March, Bangladesh goes for government holidays. Up to this time, those are relatives from outside the Uttar Tolabag. They tried to came in, but we didn't allow them because of there was police security guard and didn't get them. It was so much challengeable that time.
So last one from the chat box. How you follow up mixing of apartment people and slum people of that community?
I have already answered this
you already answered.
by road. I didn't by security guard didn't allow them to gather in the road, and there was another pocket gate for slum only. It was within the community a slum that was have one pocket gate, and with the passes through road that was maintained by leader of the slum. And there was another thing, the thermal scanner. If anyone come out for any things that in grocery store, they had to go through the thermal scanner.
Okay. And how many cases were found COVID-19 positive from the slum area? In the Tolabag, there is a slum area also.
Yeah. We have taken the samples from symptomatic people of slum area, but no one was positive from slum.
Okay.
Only the apartment people were positive.
So please.
Dr. Farooq, thank you very much for a wonderful study and smart presentation. Actually, I have two questions. And so, number one, that containment in Tolarbagh started from the 17th March, and actually the nation went for lockdown from 26th March. So, if we consider the Tolarbagh is a success story, so the nationwide lockdown is also added for the success story, right?
Yes, sir.
If there is a nationwide lockdown, so Tolarbagh history will be maybe different. So, what do you think? If there is a no nationwide lockdown, is Tolarbagh model works for the any other part of the Dhaka? Number one. Number two, do you have observed any comparison between the outside the Tolarbagh and inside the Tolarbagh about the COVID hygiene practice? The number of how many percent are using the mask, the other practices, the distancing in the mosque and the common areas, like that. So, is there any comparative study when there is a lockdown, nationwide lockdown outside the Tolarbagh and containment in the inside the Tolarbagh?
Thank you, sir. Thank you, sir, for your nice questions. For question number one, I already said that I didn't know that first time that I will go for and we will go for that localized containment approach, as we have go there for outbreak investigation. When we see that cluster, then we go for the localized containment. And after that, when our Uttar Tolarbagh, we have closed this intervention in different jela like Norsingdi and Gazipur. There were localized containment. And also we have many examples like Bhilwara, Rajasthan in India. That was also a successful localized containment outside Bangladesh. And and for second question, sir, we see that in first time, in the first portion of the COVID-19, when we go for the national lockdown, there in people there were fear, but it is listening day by day. After I don't know why there actually what can I say or what should I say? Because no one maintaining this type of social distancing. Only when the intervention was in the Uttar Tolarbagh people maintained the social distancing, but just behind the gate, just behind the main gate, there are people, they are not using mask, they are not maintaining social distancing. Gathering, just outside the main gate, they are gathering. Like many professionals, they are with camera and other people also there. Inside maintaining, but outside not maintaining.
Okay. Thank you, Major Muhammad Farooq Ahmed, so for your nice presentation, and and successfully completing the question and answering session. Thank you. Thanks again.
Thank you, sir.
Now I am requesting and inviting Dr. Sohail Rahman. He is a medical officer of IDCR and he is the fellow of cohort 4 probably. FETP? Fourth cohort fellow. Thank you. So Dr. Sohail Rahman. So his topics is containment of the first reported COVID-19 cases of the northern Bangladesh in 2020.
Somebody need help? Got it. Screen আসছে না। Shall I start? Thank you, learned moderator. Dear audience, good evening and Assalamu alaikum to all. This is Dr. Sohail Rahman, FETP graduate and now working with IDCR. I welcome you all to my presentation at First Bangladesh Congress on Epidemiology and Public Health 2021. Sorry for the inconvenience. Where? Okay, close it now first. এটা কি? Okay. No, okay. Thank you. Sorry for the interruption. So let's start from the notification of the cases. On 25th March 2020, two travelers from USA, family members actually, mother and her son, tested positive for COVID-19. The health manager of Gaibandha, a northern district in Bangladesh, reported this to IDCR. Response. On that very day, National Rapid Response Team immediately responded to this event for containment of COVID-19 disease in that district. The response was from 25th March to 23rd May. Now comes to methodology. We did contact tracing of primary 2 cases, listed their contacts accordingly, tested them, followed them, and took several containment activities. Prior to that, we did defined our cases and contacts. For contacts, anyone who was within 3 feet of a confirmed COVID-19 case for 15 minutes, starting from 2 days before illness onset to become tested negative. And for confirmed COVID-19 cases, anyone with a positive reverse transcription polymerase chain reaction, that is RT-PCR positive for COVID-19, irrespective of symptoms, from 19 to 25th March 2020. Samples were collected from symptomatic contacts and real-time RT-PCR was done. Face-to-face interview or telephonic interviews were conducted for case investigation and contact tracing. During case investigation of 2 primary cases, infection control and prevention, that is IPC, was maintained. Accordingly, as per COVID-19 guideline. Here we can see in a picture, interview of common contact of primary 2 cases. Containment. With support from district administration, we ensured quarantine for contacts and institutional isolation for primary cases. We started several containment activities like restricted movement, miking to encourage people for use of masks, to maintain quarantine and isolation as per needed, and to maintain social distance. We distributed leaflets and posters. Now results. In contact tracing, we find 3 interesting points. First one is the primary cases attended 3 wedding ceremonies. Number 2, primary case had close contact with relatives, neighbors, friends from 4 upazila of Gaibandha, Bogura and Dhaka district. Several contacts of 1 upazila attended upazila election, thereby exposed to mass community people. So we started with wedding ceremonies. Here we can see in the table the contacts of primary 2 cases by wedding ceremonies. In wedding ceremony 1, there were total 27 contacts, 11 were symptomatic, 10 tested, got their test, and 1 was positive by RT-PCR. In wedding ceremony 2, there were total 70 contacts, 26 were symptomatic, 24 got tested, and 2 were positive. In wedding ceremony 3, 18 were contacts, 3 were symptomatic, all of them got tested, but no one positive. So total 115 contacts were there, 37 were tested, and 3 were positive by RT-PCR. So finally, we got 3 cases, 3 new cases from the contact tracing of the primary 2 cases. Now let's go with the 3 new cases. Sorry. In this table, we can see the contact tracing of 3 new cases reports. We see total 122 contacts were there from 3 new cases, but there are overlapping of the contacts with the primary cases. So actually there were 42 contacts, and 18 were symptomatic, no one get tested positive. So finally, we get 5 positive cases with RT-PCR positive, mild cases, and 157 contacts. And all 157 contacts were quarantined for 14 days, either in home or in institution. And for the confirmed cases, isolation was, they were isolated in designated isolation centers and follow up until they got negative. Here in the picture, we can see the quarantine and isolation center that was created, that is Ansar and VTV Training Center. Few pictures, our team, with the help of district administration, health administration, we prepared this. Here is some picture of containments. We can see picture of movement restriction, home quarantine, social distance maintaining, and isolation center at a hospital. From reporting of last case in the outbreak, we tested 55 symptomatic cases, and later on 206 suspected cases up to 23rd May 2020, and all were tested negative. So this indicates our containment activity was successful, though we have few limitations. Number 1, in contact tracing definition, we took people who had 15 minutes close contact with confirmed cases. In this situation, we had to rely on the statement of the primary cases and listed contact. And number 2, we collected samples only from the symptomatic contacts. Conclusions and recommendations. Immediate contact tracing and collaborative effort of the district administration and health authority, the first reported case of COVID-19 cases were successfully contained in Gaibandha district. Therefore, we recommended implementation of similar contact tracing and collaborative actions by local authorities to those districts having low positivity rate currently. Number 2, keep travelers in quarantine despite having negative report. Here we can see some pictures of field activities. We demonstrated the sample collectors about IPC. Our team moved to the Bogura district for contact tracing in picture. We acknowledge IDCR, Civil Surgeon Gaibandha, Upojala Rapid Response teams of Gaibandha, IDCR Lab and WHO. And this is all about of my presentation. Thank you all. Thank you very much.
Thank you, Dr. Sohail Rahman. So there is a lot of question at the chat box. What was the criteria for telephonic interview, and for whom did you consider face-to-face and for whom telephonic? So there is a two question, face-to-face and telephonic.
Thank you, sir. First, we tried to take, for the contacts actually, we tried to take face-to-face interview. When it was not possible, we can cite an example. One contracts were in Dhaka. So at that time, team couldn't move to Dhaka. We took telephonic interview at that time for that contracts.
Okay.
Thank you.
And another one, that what would be our home-taking message for us from your study?
From my contact tracing activities and containment activities, home-taking message is for containment, few activities like restricted movement, isolation quarantine where needed, and social distance maintaining is very much essential. With these activities, we can contain an outbreak in primary stage if we tried wholeheartedly.
Yes, that gathering, it is important.
If we
avoid the gathering.
Yes,
right.
It is
important. And did you test all the contacts? What criteria did you consider for testing in a contact?
So
we can see that you did not rely on symptom for testing.
Yeah.
So
actually, most of the cases were asymptomatic.
Okay.
And in primary stage, when two cases were there, primary two cases, one cases were symptomatic, one was symptomatic and another was asymptomatic. And in initial state, we found that people are not telling about their symptoms, they are hiding. When we got assured them, gradually they revealed themselves, said about that I have got cough, I have got fever, low grade. For our recruitment, we took the patient who are symptomatic, and then we tested them for the COVID test.
Okay. Okay. Is there any question from audience? Anyone? So it is important as one of the example in my family that there is no symptom in my family members, but a few symptom, flu-like symptom they had, but when they tested, they became the positive.
Yes.
So this is the important for always maintaining the physical distance as well as avoiding the gathering, and another one is the avoid the public transportation. It is the important. So thank you, Dr. Sohail Rahman, for his fine presentation and answering the question. Thank you. Thanks again.
Thank you, learned moderator.
Now I requesting Dr. Farjana Islam Khan. She is a medical officer of IDCR, and she is the fellow of the 4th cohort of FETP. Dr. Farjana Islam Khan.
Thank you, sir.
And her topic is zonal lockdown approach to contain COVID-19 in East Rajabazar of Dhaka North City Corporation in 2020. Dr. Farjana.
Thank you, sir. Good afternoon, everyone. I'm Dr. Farzana Islam Khan. I'm a medical officer working at IEDCR, and I was the fellow of FETP 4th batch or 4th cohort. My topic is zonal lockdown approach to contain COVID-19 in East Rajabazar of Dhaka city in 2020. Here is an overview of my presentation. I will not talk much about COVID-19 or SARS-CoV-2 as it has already been discussed several times. I will go straight to the zonal lockdown approach to contain COVID-19 and how we implemented the zonal lockdown. Also, how we conducted a COVID-19 surveillance in the lockdown area. We calculated the weekly tests, confirmed patients, and also we calculated the positivity rate. And finally, we will comment on the effectiveness of lockdown in reducing the burden of COVID-19. In the face of the upsurge of COVID-19, the government of Bangladesh implemented a zonal lockdown approach in mid-2020. In Dhaka city, areas with more than 60 cases per 100,000 population in previous 2 weeks were identified as red zones. And the first area to pilot the red zone was the East Rajabazar. It is a small locality in the Ward 27 of Dhaka North City Corporation. And here, in the previous 2 weeks, 22 cases were reported, which led to a reporting rate of 85 per 100,000 population. So that was a high rate of reporting. And also this area was selected because it was feasible to lock down that area. It had only 2 specific openings. So locking those openings helped in locking down this area. Our objective of the piloting was to assess the effectiveness of zonal lockdown in reducing the number of COVID-19 cases. And how we did this. Study area, as I already mentioned, was East Rajabazar, a small locality in Ward 27 of Dhaka North City Corporation, and the study population were the residents of East Rajabazar. The lockdown period was for 3 weeks, starting from June 10 to June 30. We followed through the area and for another 6 weeks. So the follow-through period was total 9 weeks up to August 11. How the implementation was done, local police restricted the movement to and from the area during the lockdown. Supply of daily necessary items were maintained by mobile carts. Most of the shops inside the area remained closed except for drugstores. We conducted surveillance for COVID-19 within the lockdown area, and we defined any person from East Rajabazar having fever or cough or breathing difficulty or sore throat as a suspected patient. Announcements from mosque, miking, and leaflet distribution were done to increase awareness for testing among the suspected patients. We established a sample collection booth with support from BRAC in the middle of the lockdown zone. It was established in a closed school. And here you can see the booth for sample collection. Patients took appointment over phone for sample collection so that social distancing is maintained. So here you can see that proper social distancing was maintained during sample collection. After sample collection, the samples were tested at the virology lab of Institute of Epidemiology, Disease Control and Research by real-time RT-PCR test for SARS-CoV-2. We defined the confirmed patients as any suspected patient with a positive result for real-time RT-PCR for SARS-CoV-2. We isolated the confirmed patients at home, and if required, they were transferred to hospital. We conducted case investigation for all the confirmed cases by telephonic interview. We used a semi-structured questionnaire. We took their demographic and clinical information. Also, we conducted contact tracing for every confirmed case. IDCR conducted the contact tracing and also trained local volunteers to trace the contacts locally. We supervised their contact tracing activities as well. And we defined the contacts as any person who was within 1 meter of the confirmed case at least for 5 minutes. Contacts were quarantined, and we tested the symptomatic contacts. We calculated the total number of suspected patients, number of confirmed patients, and we calculated the weekly positivity rate by dividing the number of confirmed patients in a week divided by number of sample tested in that week. So this is how we calculated the positivity rate. Now the results. In the total 9 weeks period, we identified total 439 suspected COVID-19 patients, and 142 of them were confirmed. As you can see, the highest number of suspected and confirmed patients were identified in the first week of the lockdown, which gradually decreased, but there was some increase in the third week of the lockdown. Later on, the number of both suspected and confirmed cases decreased. If you look at the positivity rate also decreased in the second week but increased in the third week. Later on, it fluctuated because of the low number of samples tested. We identified total 301 contacts, among them 41 were missing. Among the contacts, we confirmed 48 patients. 48 of our confirmed patients were from the contacts. Now about the confirmed patients, their age ranged from 3 years to 85 years. Mean age was 38 years. Most of them were males. 68% or 88 patients were male and 32% were female. We collected clinical information from 137 patients. 80% had fever, 37% dry cough. Loss of taste and loss of smell was complained by 17% and 14% respectively. Other complaints were sore throat, diarrhea, headache, shortness of breath, fatigue and body ache. In conclusion, we can say the lockdown effectively reduced the burden of COVID-19, both suspected and confirmed cases in East Rajabazar area. However, even 6 weeks after the lockdown, cases continue to be detected in the area. We recommended implementation of similar approach in other areas with a high burden of COVID-19. We acknowledge all implementing partners, including Dhaka North City Corporation, A2I, BRAC, Shere-Bangla Nagar Police Station, and local volunteers. Thank you all. For any further query, you can communicate with me through email.
Thank you, Dr. Farjana. So there is a question, and as I see, that is the Jini question. The area is locked by a gate. Do you think that this helped you during containment?
Yes, actually the area was selected because it had 2 specific openings and both the openings had gates. So locking down that area was easier than compared to locking down other areas, and these gates were locked throughout the period, and also policemen were giving guards in front of the gates.
Yes.
So it definitely helped.
Yes, yes. Law enforcing agency people and
were deployed there.
Local leaders,
yes,
basically they helped. And what type of surveillance can you done in the lockdown area?
It was a passive surveillance because we encouraged the suspected patients through miking and leaflet distribution to come to the booth and give samples. It was not really active because we did not move house to house to search for the patients, but yes, it was a very strong passive surveillance.
And what would be the step of establishing emergency surveillance in lockdown area now?
In lockdown areas, we can establish both passive surveillance as well as active surveillance. In another part of Dhaka city, we conducted active surveillance.
Okay, thank you. So any question from house? Okay.
Thank you, Dr. Farjana. It was a nice presentation. I just want to know that we know it was the first general lockdown in the country. So, and there was so many multi-sectoral collaboration there. So, do you feel any difficulties to implementing your lockdown?
Yes, like every approach, even here there were some difficulties. Some unauthorized movements were there. And as you can see in many newspapers also reported that some unauthorized movements were there, and it was not possible to completely restrict the movements. Also there were vehicles and carts for business Some of those sellers were not maintaining proper distance, or some of them were not using the masks properly. So these issues were there.
Okay, thank you.
So anyone? Okay. Thank you, Dr. Farjana Islam Khan, for her nice presentation and answering the question. Thanks again.
Thank you, sir.
So now I am requesting the last presenter of this session, Dr. Shahata Jarab Salihin. He is a medical officer of IDCR as well as the fellow of the 5th cohort of FETP, Dr. Shahata Jarab Salihin. And his topics, zonal lockdown approach to contain COVID-19 infections in rural sub-district of Bangladesh in 2020.
Is it coming or just need to share the screen? Where is the? Okay, I'm trying. Dr. Salim, okay. Respected moderator, distinguished audience from home and abroad and who are attending through offline and online, Assalamu alaikum and a very good afternoon. I am Dr. Shahata Jarab Salihin from IDCR Bangladesh. I am going to give my presentation on the zonal lockdown approach to contain COVID-19 infection in a rural sub-district of Bangladesh. Actually, the first COVID-19 case was detected in Bangladesh on 8 March, and after detection of the first cases, all the educational institutes were closed on 17 March. And to stop the further spread of COVID-19 transmission, government also declared nationwide holidays and provide ban of domestic travel on 23rd March. The current scenario till 31st March of 2021, there was total 925 cases detected, and the total 9,046 deaths were reported till today, till yesterday. So as the country-wide lockdown is difficult to implement, the government of Bangladesh took an alternative initiative to lock down the zone instead of whole country lockdown from 9 June 2020 to mitigate the COVID-19 spread. And for this purpose, all the sub-district and district of Bangladesh are divided into red, yellow, and green zone on the basis of diagnosis of COVID-19 cases per 100,000 population. From the, it is actually detected from the past 2 weeks. Here you can see the red, yellow, and green zone. As my area was in rural zone, for case of rural zone, if there is more than 10 cases per 100,000 population, then it was considered as red zone. And if there is 3 to 10 cases per 100,000 population, that is considered as yellow zone, and less than 3 cases are considered an green zone. So the objective of my study was, one objective was to compare the COVID-19 cases incidence and test positivity rate before and after zonal lockdown, and another was to assess whether zonal lockdown can be used as alternative to country lockdown to contain the COVID-19 pandemic. This study was actually an interventional type of study, and the place was from Kaliganj sub-district, and the study period was 30 May 2020 to 17 July 2020. And actually 3 wards from Kaliganj sub-district was selected for the zonal lockdown containment, and the total area of that 3 wards were 5.6 square kilometer with population of 33,695. And at that time, before starting the zonal lockdown, there was total 184 per 100,000 cases of COVID-19 cases were detected before starting our zonal lockdown. So that's why it was declared as the red zone. For zonal lockdown, in our interventional activity, we gave temporary boundary in the zonal lockdown area and just maintain one exit point and one entry point, and which was guarded by the local volunteer and police. Here you can see the picture. The entry and exit point was guarded by the police. And there was also testing booth. We also set up testing booth for 24/7 for the testing facilities of the suspected COVID-19 cases. For food and medicine, the local volunteer also supplied food and medicine 24/7 to the community. And there are 3 dedicated ambulances with the mobile health team who are all-time responsible for any type of emergency purpose of the both COVID-19 and non-COVID-19 patients. And for awareness purpose, they also used like banner, festoon, and hand mic for just creating the awareness on social distancing and mask using. So in our case definition, we defined the confirmed COVID-19 case, any person tested positive for RT-PCR at the 3 wards of Kaliganj sub-district of Gazipur from 13 May to 17 July 2020. Those are considered as a confirmed case. And in case of active case, any confirmed COVID-19 case of ward 3, 4, 5 of Kaliganj sub-district from date of diagnosis to 14 days were considered as active case. And here is the calculation. We calculated the COVID incidence rate and COVID-19 positivity rate. For case of COVID-19 incidence rate, COVID-19 positivity rate of that red zone area divided by the total number of population of that area, which was expressed by 100,000 population. Then we considered it as incidence rate of that area. For positivity rate, we also calculated the total number of the COVID-19 positive case divided by the total number of sample tested, and it was expressed by percentage. It was incidence and positive rate of that area. And for this, we performed Z test for 2 proportion for the COVID-19 incidence and positivity rate before and after lockdown. We also set the p-value at less than 0.05 as a level of significance. In our findings, you can see the graph. It's actually a snapshot of Gazipur. The first case was detected on 24th March, and before lockdown, it was total 584 cases were detected. And here is the scenario of the lockdown area. You can see the before lockdown, during lockdown, and after lockdown scenario. This epicgraph shows after giving the intervention, there is significant decrease of the COVID-19 cases before rather than the during and before intervention. And it's also this graph also shows the incidence rate of before lockdown, during lockdown, and after lockdown. Before lockdown, it was 180 cases per 100,000 population. During lockdown, it was 139 cases per 100,000 population. And after the intervention, it decreased up to 8.9 per 100,000 population. And here is the positivity rate. You can see the positivity rate also decreased. Before lockdown, it was 22.7%. During intervention, it was 7.4%. And after the intervention, it was only 1.2%. There are some limitation in this study, like there is absence of control area. It was piloted on a single area, and so there is lack of generalizability or representativeness and absence of long-term follow-up. So from these findings, I would like to conclude by emphasizing the fact that after implementation of zonal lockdown, COVID-19 cases reduced in a rural sub-district area. We recommended to implement zonal lockdown in multiple areas of the country and analyze the finding to see the effectiveness of the approach, to conduct a qualitative study in the population of containment area to find out the acceptance of approach in the population. And in the end of the presentation, I would like to acknowledge all the below mentioned institute for supporting me during my intervention. I would again thank you for your patient hearing.
Thank you, Dr. Shata Jarab Salihin. So, there's a question from the chat box. So how many departments were involved during implementation of the zonal lockdown?
Thank you, sir, for the question. Actually, it was not supported by only the health department.
Yes.
There was multi-sectoral approach. So, police department from the local area, also the district commissioner, that is the local administration, and the local people, local community, that they act as a volunteer. This total group act with the health department to implement this lockdown. So it was not on the single approach, it was multi-sectoral approach.
Yes, yes. As because only the health cannot
contain the COVID-19 only.
Yes, total implementation of the lockdown. So how smooth was the interdepartmental communication at that time?
Actually, during the lockdown period, red zone zonal lockdown implementation period, it was smooth because there was a sectoral intercoordination. But actually, in case of long-term follow-up or long-term implementation, I think it will not be that much smooth because a dedicated team or trained team will be needed if we want to run this type of intervention for long-term intervention implementation. So that time it was smooth, but if we run it for long-term, then I think there will be more manpower, more logistics support.
Yes. Do you consider that this type of lockdown a good strategy to be applied in other countries from your experience?
Actually, sir, it depends because in a Bangladeshi situation, there is one kind of strategy. But if we apply in some other countries, if there are good intersectoral coordination like that with the coordination between the health ministry and the administration, and also if there is enough manpower, trained manpower especially for the containment, then it can be applied in any other country because we are kind of successful in our zonal implementation. So it can be also applied in other countries too.
Okay. What should be the approach to maintaining social distancing within a lockdown area?
As it is declared as a red zone, so it's better to stay at least home without any emergency purpose. Anybody should not coming out from his house because already the volunteer is serving 24/7 for medicine, for drug, or for any necessary purpose. So I think it's better to stay in the home rather than moving. And it is also as a citizen, it is our responsibility to support our government too. Only government can just control this type of pandemic. So as a citizen, we should also maintain social distancing, support the government to implement this type of lockdown or any kind of lockdown.
Okay. How can we renovate these lockdown measures for current upsurge of COVID-19?
This is very interesting question. Again, already, there is a circular from the government. Like they already took some initiative restricting the movement in the high pandemic area or highly contagious area. They also declare order for the restricted the function, the social function, the traveling, the trip. So I think for this situation, maybe in near future, government is also again go for this type of lockdown again to contain the COVID-19 pandemic.
So, any question from the house? Yes, sir.
Sir, please.
Thank you. Really very interesting and informative presentation.
Thank you, sir.
I have this, you can say, question or observation as well. Number one is you said 30% in the urban area and 10% in the rural area red zone.
Yes, sir.
My question is it according to the population density or not? And number two question is, do you recommend any suggestion for the buffer zone around your containment zone? Okay, any health education or any measures so that can help in the long run? Thank you.
Thank you, sir. Sir, actually it was when government declared on 9 June about the zonal lockdown matter, they already give us the formula. It was that time, it was kind of the formula that if any urban area, if there is more than 30 cases per 100,000 population. So why they give this 30? Because in, you know, already in urban area there is more crowdy, but in rural area as there is less crowdy, so it was like only 10 per 100,000 population. So it was actually decided by the government on the basis of the population or density of that area. It was the answer of the number 1 question. And for number 2 question, yes, actually as that area is declared as red zone, maybe there is yellow zone surrounding the red zonal area. Maybe there is 3 to 10 per 100,000 population already detected in the yellow zone area. So for the yellow zone area, there are some also instruction, like restricted of the movement or restricted of the unnecessary movement and maintain the social distancing using mask. They can move, but they have to maintain this thing. So for yellow and green, for yellow zone, they have to maintain. They have to also maintain some instruction like the red zone. Thank you, sir.
Thank you, Saren. Another question.
Yeah.
How could you manage the non-COVID emergency patients in the lockdown area that time?
Yeah, already, thank you, Dr. Sajjad. Already we have faced this type of situation during our lockdown. Actually, I already mentioned there are 3 dedicated ambulance for the COVID-19 patient, but there were 1 standby ambulance which was dedicatedly used for the non-COVID patient, and in that ambulance, no COVID patient transportation were maintained in that non-COVID ambulance. So it was the approach during our lockdown. So there was total 4 ambulances, 3 were for COVID-19 emergency management, and 1 was for the emergency management of that area.
So thank you, Dr. Shata Jarab Salihin, for his nice presentation and answering the questions. So I thank you again. I thank to all the 5 presenters of this session, especially the containment of COVID-19 situation during 2020.
Thank you, sir.
They explained their experiences, what they did at that time during the in 2020. So lockdown is not the only the measure to containment the pandemic situation. So it is a multi-sectoral approach that we learned from our presenters, that it is a community approach as well as the government instructions. So right now our government already instructed the 18 points should follow for the current for reducing the current situation of the COVID-19 cases. So we should follow the 18 instruction that already issued by the government of Bangladesh. And there is some responsibility of the citizen also. They should follow, and they should obey the public health measures and the other instruction by the government. So still we are not following all the instruction that is already issued by the government of Bangladesh. So I thanks to all the 5 presenters, and especially thanks the organizer, Dr. Malik Masumbillah, Dr. Farsim, Dr. Salihin, Dr. Jafrin, and Dr. Nabi for organizing these sessions. And all thanks to our director IDCR for her nice contribution for organizing this session, as well as thanks to the US government, especially the Center for Disease Control and the Epidemiological Association of Bangladesh. And it is our new experience that the online platform, we are using the online platform for conducting this session. Thanks to all. Thanks.
Thank you, Ashrafi Bhai. Actually, I want to say something to the IDCR fellow who did a great job regarding this. They were involved in this lockdown issues. So here we could see there are several attempts of lockdown which was conducted by IDCR, and we found the effect of this lockdown mechanism. So out of this thing, we came to know that it's an effective thing, but we cannot do this for a long period of time. But out of this thing, I mean, we learned something, and we can make a strategy for the next or upcoming pandemic, or even now the cases rising day by day. So we can actually document those things that IDCR did from the beginning of the pandemic till now, and we can also identify the gap during conducting this lockdown or involving in the lockdown. And so after and when we will look at these gaps, we will be able to know how can we overcome those difficulties or challenges the fellow at that time they faced. So out of this, I mean the thing through which they went through, we can make a strategy, and we can also give it to the policymaker so that it can be implemented even now when the cases is rising. So I would request all of you to make a document out of these findings that you got throughout this period of time, and also point out the challenges that you face, and try to make the thing, or try to think about the matters that how can we overcome those challenges. It will be a very good approach. Thank you.
Thank you, Madam. And thank you, Moderator Sir, for conducting the scientific session. Now I request our, we humbly request our chairperson of the closing ceremony of this Congress, Professor Dr. Tahmina Shirin, Director IDCR Madam, to the dais. I requested, Madam, and I requested Dr. Ali Akbar Ashrafi sir to take the crest for the nice moderation in the last scientific session of the first Congress, Bangladesh Congress on Epidemiology and Public Health 2021. Give a big hand for them, please. Now I requested Dr. Mohammad Farooq Ahmed, then Dr. Sohail Rahman, Farzana Islam Khan, and Shah Tajarab Salim, one by one, to collect their crest and certificate of oral presentation from Madam and Moderator Sir. Give hands for them, please. Thank you. Now, dear ladies and gentlemen, we are at the last part of the first Bangladesh Congress on Epidemiology and Public Health 2021. I requested Dr. Mustaq Hossain sir and Dr. M. Selimujjaman sir to be cooperation with Madam, Director Madam, at the last session, closing session of first Epidemiology Congress. I requested three of them to come at the dais. global public health experts, respected officials from the Ministry of Health, as well as representatives from international agencies and NGOs were attended in our Congress. Plenary sessions, roundtable discussions, and of course, presentations of epidemiologists gave us a new dimension of thinking and working together. Development of clinical management of a health system has enormous importance, but application of epidemiological methods in response to public health emergencies was our theme, has had an impact for years. Now, we humbly request our chairperson of the closing ceremony of the Congress, Professor Dr. Tahmina Shirin, Director IDSR Madam, to the dais to take her seat. And with her, I also requested Dr. Mustaq Hussain sir and Dr. M. Selimuzzaman sir to the dais. Mr. Muhammad Ali Noor, Honorable Secretary, Medical Education and Family Welfare Division, Ministry of Health and Family Welfare, Government of the People's Republic of Bangladesh, has honored us to be the chief guest of the joint event. He will join with us in online. He joined in online. And also Professor Dr. A.H.M. Inayat Hussain sir, Directorate General of Medical Education, DGME, make us proud to be the special guest of the closing ceremony. After 8 March 2020, IDCR, FETP, all were busy with COVID-19 duties. In this pandemic situation, 24/7, they work on the field, they work for country, they work for mankind. We have no way of respect them in money or in salute them, but in this Congress, we want to respect them through a gift of, through a crest of our respect. Now I requested the frontline fighters of COVID-19 to take crest from our guest from the dais. Now I call Dr. Prince to come at dais and take his crest of honor. Please, Dr. Prince. One by one, I will call your name and you will come to the dais and take the crest from our respected madam. Then Dr. Sayyada Tasnuba Maria. Please, Dr. Sayyada Tasnuba Maria. Dr. Sabrina Mohana. Then Dr. Alpona Mujumdar. I requested all of you to come to the dais one by one. Then Dr. Jinnatun Nabi, 6th cohort FETPB. Dr. Ashish Kumar Kundu. Dr. Jafrin Jahed Jiti. And next, Dr. Mohammad Farooq Ahmed. Dr. Mohammad Tawhidul Anwar. Please give a big hand for them, please. There is a leg. Dr. Shubroto Malakar, Dr. Jahidur Rahman. We know that we are at COVID situation. For that reason, you should maintain the social distancing when you came to the dais.
Now I'd call upon the FETP graduates from the 5th cohort, Dr. Farsim Tarannum Haq, Dr. Qazi Tahmina, Dr. Qazi Tahmina, Dr. Tonima Islam, Dr. Debashish Kumar Shaha, Dr. Mohammad Shahadat Hussain, Dr. Shahata Zarab Salehin, Dr. Shah Muhammad Mohibullah,
Now, I would request Dr. Muhammad Afzalur Rahman. Then Dr. Nusrat Sharmin Poppy. Dr. Muhammad Omar Kayum. Dr. Sohail Rahman. Dr. Farzana Khan. One of our graduate from 3rd cohort, Dr. Nauroz, she worked for COVID-19 from the first of the call, but Dr. Nauroz is at this moment COVID-19 positive. For that reason, he cannot attend this Congress. Now I call Dr. Mohammad Rashid. Dr. Mona Lisa. She is absent maybe. Dr. Mollik Masum Billah. Dr. Qazi Ahmed Jaki. He is also absent there. Now I request to collect the certificate of presentation, poster presentation of this Congress. Please come one after one and collect your certificate of presentation from Chairperson of the Congress. First of all, Professor Dr. Nasima Sultana, Dr. Mohammad Firdaus Rahman Sarkar, on behalf of Dr. Firdaus Rahman Sarkar, I requested Dr. Mohammad Omar Qayyum to collect this certificate and crest. Then Dr. Jinnatun Nabi. I requested Dr. Jinnatun Nabi. I request Dr. Jafrin Jahed Jiti. Dr. Muhammad Tauhidul Anwar. Poster presentation.
Dr. Mohammad Mohibullah Shourab. Dr. Mohammad Tauhidul Anwar. Dr. Mustafa Mahtab Toaha. Dr. Tonima Islam. Dr. Shirajul Islam. Dr. Muhammad Omar Qayyum. Dr. Ashish Kumar Kundu. Dr. Saida Tahmina Firdaus Jinia. Dr. Sohail Rahman. Dr. Geeta Rani Devi from CBSC. Dr. Samia Akhtar's crest certificate will be received by Dr. Omar Qayyum. Now we request Dr. Mollik Masum Billah, Senior Scientific Officer of Epidemiology Department of IDCR, to give us a speech on his experience of COVID-19 and on the performance of the frontline.
So, thank you, Farjana. Honorable Chief Guest, our Chair and a special guest, It is our great opportunity that we get to participate in this conference and shares a lot of activities of FETPB course. And we are actually great. We are for great pleasure that our secretary sir is online. So we want to give a short introduction of our FETP course to him. Then we'll start a small talk. So please, sir. Sound in.
Who has given their life to something bigger than oneself. A hero is a disease detective. Become a national leader in public health. Learn by doing. Lead outbreak investigations across Bangladesh. Challenge yourself to see health and medical care from a new perspective. Develop your scientific thinking skills. Join a family of FETP graduates from more than 80 countries. Interact and learn from global experts in public health. FETPB is an on-the-job, full-time fellowship focused on field-based applied epidemiology and general public health leadership. FETPB fellows evaluate and improve surveillance systems, develop health communication skills, and conduct public health field research on the most important health issues facing the country. FETP is modeled on the 50-year-old flagship CDC Atlanta program to train its core epidemiologists and public health leaders called the CDC's EIS program. In 2013, the Institute of Epidemiology, Disease Control and Research, IEDCR, started the FETP program in Bangladesh. It is the first ever 2-year residency course on applied epidemiology in Bangladesh. Fellows get books, laptops, monthly stipend, accommodation facilities, and grants for research. Fellows get opportunities to present at national and international conferences. Fellows spend 20% time in the classroom and 80% time in the field. Government medical doctors, government veterinarians, and doctors of the Army Medical Corps can apply. Successful graduates will be awarded 2 certificates, one from US CDC and one from the university as a master's degree in applied epidemiology. Graduates can be promoted as assistant professor, run public health programs, or lead national, district, and Upazila rapid response teams. FETPB residents and graduates are our boots on the ground in the ongoing battle against public health emergencies. Join FETPB and be a disease detective.
So we are very glad that Bangladesh government started this course in 2013, and this course actually gives the opportunity for the government doctors to be disease detectives and also participate in national public health responses. I just want to mention that, sir, this is a course that is we have affiliated in Dhaka University under the instruction of order from the ministry. So now we are actually taking the opportunity to affiliate the course in Bangabandhu Sheikh Mujib Medical University. So this is a course that is already our medical doctors are getting deputations. And the participants of this course that you saw, sir, they actually worked from the March 8 and they worked in the hotlines, case investigations, and we have a lot of presentations of these fellows. And our director madam will have the presentation, and this presentation will show also the activities of the FETP. For this conference, I would like to thank IDCR and the USCDC and also Epidemiology Association of Bangladesh to give opportunity to Field Epidemiology Training Program Bangladesh to participate and organize the conference and make it successful. I want to thank all the fellows and graduates to help me to complete the conference. This is a first time experience for us and also in Bangladesh to arrange a conference on the online and offline version. So this experience is successful. I think in the next year we can also arrange this type of conference. Also, the conference is one of the criteria for the Field Epidemiology Training Program, that our fellows need to present their activities, and this is one of the deliverable to complete the course. I also want to thank some of the fellows and graduates like Dr. Kaji Ahmed Jaki, Dr. Rabbani, Dr. Qayyum, Dr. Nusrat, Dr. Firdaus, Dr. Noroz, Dr. Rashid, Dr. Sohel, Dr. Farjana, Dr. Salihin, Muhib, Devashish, Farsim, Dr. Tawhid, Jafrin, Shubroto, all the fifth cohort, sixth cohort and seventh cohort. They actually worked day and night to make the program successful. So this is an opportunity for us, and also this is a gateway for us in the next conference. Thank you, and hopefully we'll be successful more in the next years. Thank you.
Now we humbly request the chair of the closing program, Professor Dr. Tahmina Shirin Madam, to give her presentation on IDCR.
Presentation.
Honorable Chief Guest, Muhammad Ali Noor, Secretary, Medical Education and Family Welfare Division. Honorable Special Guest, Professor Dr. A.H.M. Enayat Hussain, all the distinguished guests and audience online and offline, Assalamu alaikum and good afternoon. Now I will say very briefly about the IDCR and its activities, role in surveillance, outbreak and researches. So the IDCR, it stands for Institute of Epidemiology, Disease Control and Research. Actually, it was established in 1976. Then in 2007, it was designated as National Influenza Center. All of us, we know that there are 143 national influenza centers over 113 countries. Bangladesh is one of them. IDCR is a focal institute for NIC that I already mentioned, National Influenza Center, Global Health Security, One Health Secretariat, National Health Regulation, Foodborne Emergency Response, Global Health Detection Center for US CDC. Actually, we are working in collaboration with different university here, and we have also collaboration with the global organization that you can see on the screen. This is the organogram of IEDCR. We are basically under the Ministry of Health and Family Welfare. These are our departments, and we have 5 laboratories at IEDCR. So if we talk about the IEDCR laboratory facilities, we have BSL-2 facilities there. We have molecular techniques at IEDCR lab, serology, cell culture for virology department. We have microbiology, full-fledged microbiology department where we can identify or we can isolate the different bacterial pathogens, and also with their biochemical and serological characteristics. Other than this, we have genetic lab, which is belong to One Health, and the entomology lab, where we can see the bioefficacy of different insecticides. So this is the snapshot of IEDCR lab. So another thing is that we have another lab at Cox's Bazar Medical College, that is the IEDCR field lab. We all know that in 2017, end of 2017 and 2018, there was a huge outbreak of diphtheria among the FDMs, the Rohingya people. So at that time, actually in Bangladesh, we didn't have any facilities at that time to diagnose the diphtheria. So during that time, we got support. A team from US CDC came to Bangladesh with reagents and logistics for identification and isolation and molecular detection of Corynebacterium diphtheria, that is the causative organism of diphtheria. At that time, IEDCR did the molecular diagnosis of diphtheria as well as bacteriological isolation and sensitivity of Corynebacterium diphtheria. But we felt that it was very difficult to get the sample from the field to the laboratory and get back the report to the individual. So it was a challenge because it took time for the management. So at that time, with the support from WHO, IEDCR established a field lab there, and since then this lab is supported by WHO, and they can identify the diphtheria organism there at Cox's Bazar, and principal of Cox's Bazar Medical College, he also supported us. He gave space to build the laboratory. Until now, they are doing the same thing. But one thing is that during the COVID pandemic situation, from the beginning, they didn't get any type of support regarding the equipments from the government, because this lab is well equipped, and since the beginning of the pandemic, they are doing the PCR of COVID-19, and still they are doing. And I have already mentioned that IEDCR, One Health Secretariat is established in IEDCR in 2016, and till now it is working at IEDCR. The IEDCR is based on these 4 objectives: the epidemiological surveillance, outbreak investigation and response, training and research. So there are several surveillance that are going on at IEDCR. I don't want to mention all the things. You can see these on the screen. These are the surveillance that is going on IEDCR. One important surveillance, that is the event-based surveillance, where IEDCR monitor both electronic and print media, which 24/7, and we have the hotline numbers here you can see. So through this platform, we get the informal reporting, and when we get any type of information, we verify those information and then start doing the investigations. That is the outbreak investigation and response. And one thing that I would like to mention, that this the first cases of COVID-19 was identified through this event-based surveillance. These are the here I would like to mention the outbreak investigation response that is conducted by IEDCR. there are 3 tiers of team, that is the National Rapid Response Team, District Rapid Response Team, and Upazila Rapid Response Team. So the outbreak investigation usually go through this process. So the people who are working at IDCR, they are the member of National Rapid Response Team, with the support from district and Upazila Rapid Response Team who used to conduct this surveillance. So this is the mechanism how the outbreak response is happen. So IDCR has the POC, that is Public Health Emergency Operations Center. When there is any outbreak, the POC become activated, and it then conduct this outbreak response through coordination. And if there is any outbreak which is of zoonotic origin, in that case, not only the people from the human health sector move, along with them, the people from the animal health, wildlife, and other sectors, they also move together to respond the outbreak. This is one example of the outbreak investigation in One Health approach. This is an outbreak of Nipah. All of us, we know that Nipah virus infection is a zoonotic disease, and the virus, the bat used to is the source of this virus, and contaminated raw dead pump syrup is the cause of this outbreak. Consumption of contaminated raw dead pump syrup is the cause of this outbreak, and here you can see the bat roost, which is discovered by the EcoHealth team. Here they are collecting the samples from the bat. So we collected sample from patient, and the people who are working in the wildlife, they are collecting the sample from the bats. So the way we actually respond to the outbreak of zoonotic origin. These are the major outbreaks that usually happen in Bangladesh. So these are the frequency of outbreak that used to occur in different years. Here you can see the frequency of outbreak from 2015 till 2021. There are some snapshot of outbreak investigation. Here is the outbreak in dengue outbreak in 2019. This is also the dengue outbreak in 2019. This is the outbreak, chikungunya outbreak in 2017. And if we think about the outbreak, this pandemic situation, this COVID-19 pandemic, actually we have started working since January, when the outbreak was only limited within Wuhan, and well ahead of declaring of pandemic by WHO. So during that time, we sorted the suspected cases, and collected the sample from suspected cases, and our laboratory became activated, and we collected the sample, and we tested the sample since January 2020. And we started daily press briefing since February 2020, and daily press release in the website. We also developed health declaration form when people arrived in Bangladesh from different places, from different places around the world. And within the 3 days of arrival, we used to call them through cell phone, and we also interview them on day 10 and day 14 through interactive voice response. Our hotline was open 24/7, and we started with the 4 hotline numbers, which increased over 75 numbers, and we used to get call to 3,000 to 4,000 phone calls per day, and thus we identify the COVID-19 cases, and we routinely collect the sample from door to door, and when we get any positive case, we go for the contact tracing. And here we can see the IDSC are also involved in the quarantine activities. And when the first flight from Wuhan came to Bangladesh, all the passengers were quarantined, and we tested samples from all passengers and before they went home. And this is the activity that is still going at IDCR laboratory. And when the outbreak was declared, or the pandemic started, we right then we strengthened our laboratory capacity, and we started testing real-time PCR of COVID-19. At that time, IDCR was the only laboratory that could deliver the report. Later on, when government feel that it is not enough to combat the disease, then the number of PCR labs increases all over the country. And at that time, IDCR virology lab was also declared as the reference laboratory. So along with the routine activity, IDCR virology lab is engaged in validation of PCR test kit. They are also engaged in quality check of other PCR laboratories across the country, and also involved in the training of the new labs. Now, the research activity that is conducted by IDCR, there are some researches that is going on COVID-19 COVID-19 related, and one of the research work already published, and one is in pipeline, and other thing is half of the way. These are other research related activities at IDCR. Now, the workforce development and training program. Basically, we have three category of courses. One is the long course, that is FETPB, which is under University of Dhaka and IDCR with collaboration with USCDC. These courses started from 2013 and still it is running. Regarding the long course, we propose another two courses which is lab related. One is the MD on virology and MD on microbiology, because for any surveillance, for any outbreak, lab is a essential component along with the public health activities. And IDCR lab is well equipped, so we think that we will be able to run the post-graduation course at IDCR. Another one is the intermediate course, that is 9-month course is known as intermediate FETP-B, 3 months course that is frontline FETP, and certificate course on the clinical epidemiology. Here the postgraduate students in the clinical subject, they used to get chance in this course, certificate course. And another one is the distinguished fellow program. The manager, the senior people who are in the managerial level, they used to do this distinguished fellowship course. Another one is the short-term training. We used to provide training on disease surveillance, outbreak investigation, infection control and prevention. And we also give emphasis on the emerging and re-emerging diseases. And like if there is any outbreak in any part of the world, we used to or we want to disseminate those things among the healthcare providers in Bangladesh, not only the doctor, in healthcare providers in different levels like doctors, nurses, technologists, health managers, and different tiers of health system in Bangladesh. Like along with them, we also train the veterinarian, statistician of Upazila Health Complex. Now, the capacity of IDCR lab. Actually, I want to explain why we want to establish post-graduation course at IDCR on laboratory science. So, if we think about the capacity of IDCR lab, we have the molecular lab where we can do the PCR. It is conventional PCR, real-time PCR. We have sequencing. We can do the capillary sequencing, that is the Sanger sequencing, and also the next generation sequencing. We have serological facilities, cell culture for virus isolation. We have bacteriological facilities for the culture along with the biochemical and serological test. IDCR is a reference laboratory for AMR, that is antimicrobial resistance, COVID-19, influenza, Nipah virus, and Japanese encephalitis. And the achievement of IDCR lab, what we did at IDCR. If we think about the dengue outbreak in 2020, the first dengue cases were identified by IDCR. The first Nipah case in 2004 was identified by IDCR in collaboration with ICDDRB and USCDC. IDCR played a great role during 2019 influenza pandemic. Though this influenza didn't hit that much in Bangladesh, then IDCR also took part in the detection of chikungunya virus in 2008 and 2018. And from 2013 to 2019, IDCR is doing the molecular detection of dengue virus with its serotype. And we could identify why there was a big outbreak during 2019, dengue outbreak in 2019, as because in 2019 there was re-emergence of new serotype which was not existing in Bangladesh since 2002. That's why it created a havoc in 2019. Then H5N1 and H9N2, these are the avian influenza virus, which was also detected in human by IDCR virology lab. In 2019, we built capacity for detection of MERS coronavirus. All of us, we know that MERS coronavirus, at that time there was an outbreak in Middle East. So we also prepared ourselves for to detect this virus. And 2015, when there was an outbreak of Ebola in Africa, West Africa, at that time we built capacity for detection of the Ebola virus. We also detected first Zika case in Bangladesh. And thus in 8 March 2020, we detected first case of SARS-CoV-2 in Bangladesh. These are some publications, that is, the books and some health education materials. These are published by IDCR. We got support from different development partners and agencies to develop these messages. These are the communication materials that we developed. Now the way forward. We propose for more human resources for strengthening of the capacity of IDCR and to establish academic wing for human resource development. This is our new building, and we propose for the academic division and service division, strengthening of laboratory capacity, post-graduation of existing, upgradation of the existing laboratory capacity, and academic courses in laboratory. Workforce development. For the workforce development, we already submitted our human resources for health, for the health service and health education in the GHS. So we also want to extend our collaboration with the development partner like USCDC and others. We also extend our GHSA project, which is supported by USCDC. And we also want to extend our collaboration with other development partners. So this is our proposed organogram here. More than 800 people we want to get at IDCR, and we propose for those human resources. Thank you, sir. Sir, actually, I explain all these things because you are here with us, so you will be able to understand what is the activities that is going on at IDCR, and actually for as the national institute, IDCR need to be strengthened, and for the strengthening of IDCR, we need more human resources. Not only the human resources, the trained human resources. Thank you, sir. Thank you.
Thank you, madam. Now I humbly request our honorable chief guest, Mr. Mohammad Ali Noor, Secretary, Medical Education and Family Welfare Division, Ministry of Health and Family Welfare, Government of the People's Republic of Bangladesh, to give his speech on this closing ceremony of the first Bangladesh Congress on Epidemiology and Public Health 2021. Please, sir is joining in online in Zoom.
And respected all other members, respected guests, participants, and all other audience, Assalamu alaikum. It's my great pleasure to be here as already you have spent a huge time with all the presentation by the young doctors on epidemiology and public health regarding COVID-19, especially mentioning in lockdown. And it is the first Bangladesh Congress on epidemiology and public health, so far I came to know. Then it's another great pleasure for me to be here and to come in contact with all the expert scientists of IEDCR. Thank you very much for inviting me. And first of all, I'd like to show proper respect to the all frontliners. There is doctors, nurses, and technologists who dedicated their lives during the COVID-19 for the sake of the patient of COVID-19. And IEDCR, the name, it was totally unknown to me before joining this ministry. And sometimes we came to know ICDDRB. It is well-known institution. There is a research center, but IEDCR, it is totally, I think, unfamiliar, not familiar to everyone. As a general people, I can say. But after COVID-19, that is last March 2020, after COVID-19 invention, and there is very infection in Bangladesh, IEDCR came out in front of us as holding the steering to manage the COVID-19 patient because it is a new virus and totally unknown to the all scientists, experts all over the world, and that's why everybody's concentration and attention was only on COVID-19 news every day and every moment. And the whole world was suffering, is still suffering, and Bangladesh is not exception, and Bangladesh is also suffering from COVID-19. And still we are fighting against the COVID-19 and with a strong hand. And I could say that we are a bit successful in comparison with some other countries around us. So this is all the credit goes to IEDCR and all the members because every time we saw that the people from IEDCR, they are working with the virus. They are fighting against the virus. They are inspecting. They are going for research. They are doing a lot of things, how to identify the virus, how to manage it, how to control it, how to prevent this type of virus, and which is very dangerous for human being. So far, we came to know that 5 presentations were there. And at the last presentation, I observed a very young doctors, all the young doctors presented on COVID-19, especially regarding on lockdown. And what is the result? They explain it by their presentation, and they showed their graph and some other statistics. Though research was, there is, I could say not research, that is, it is one type of survey. Survey was in very similar, small areas. There is sample size is very small. It is not big, so representation is not so meaningful. But even that, the result, segmented result is, I think, representative of all other areas that which are published or demonstrated by the presenter. So, and some of the questions asked by some of the experts, I came to know the answers given by the young doctors. I am really happy to know that they are very much expert and going to be expert, and they are very smart enough to give the answers properly. So I am very, very happy with them, and they have suggested in several areas how to control COVID-19 and how to motivate the people, what are the main measures and strategies to be taken by the government and by all other physicians, and they mentioned it, and it's really good. But there should be, in any survey or research paper, there should be some weak point or limitations that should be mentioned. I don't know whether in other presentation it was mentioned or not, but in the last presentation, I could not find that there was some limitations or there are some weak points for their service. But even that, I think all the presentations so far, I can guess the last one, as I have observed, was wonderful and very, very meaningful presentation. Thank you very much for very much to all the young doctors, those who presented. And on other areas, as director, Ms. Tamina Shirin mentioned his presentation that all the activities of IADCR, the research work and all other training work and academic work also, there that is organogram, the human resource capacity and their capacity, what they can do and what is the laboratory facilities are there and everything. That there is you are doing a huge work in training, research and some other activities. You are always involved in all those works. And you are during COVID-19, I can remember that many times I requested Ms. Tamina, before Ms. Tamina, Flora, that is, her name is, full name I forgot, Davrina Flora. I asked her to take some sample for COVID sample test. So every time your people came my residence and took the sample and gave the result. So not only me, I think in all over the city, there is Dhaka city, your people were running here and there, and they dedicated their lives to give service to the people. And this is wonderful, and everyone should be very grateful to you all and your people. And I should say the nation should be grateful to you all, because we are successfully handling COVID-19 so far. But recent time, there is only this month, the trend of COVID-19 infection is very going up. And it is unexpected. It was unexpected. But whatever may be the causes, and you know that the causes, actual causes where only the people were not very aware of this dangerous side of this COVID-19. That is how to protect ourselves, how to move from here to there. And they were very, very, very ignoring. They were the people of this country were very ignoring about the COVID-19. They thought that after getting the vaccine, they are free. They have no fear of COVID-19, though the experts, especially Dr. Mustaq Hassan is also with you. Many times he said, and like him, other experts also expressed the ideas that it is not the medicine that will cure all on a sudden. You have to cover your face, cover your there is nose and mouth, so that there is a use mask, so that the virus cannot enter your body. So our people were very much ignorant about it, and they did not show care about it, and ultimate result is very bad for us. And we should be very careful about it. And this time government has taken initiatives and a strong stand. We are in we are taking strong position that so that to save the people from COVID-19, we have to do something very tightly and strongly. And already have known that all the tourist areas and all other conventional activities are totally stopped and declared stopped not to do. And the movement is restricted, and every office except the essential services, all the offices curtailed by the presence of its staffs and officers. So I think all these activities are going on, and this is only with the suggestion from you. And you are the only person, authenticated person, and you are the authority to give that type of suggestion for the physicians to do or follow. And thank you very much for inviting me. And I think under the leadership of our visionary leader, Honorable Prime Minister, and as well as the leader of our Honorable Health Minister, we will be able to tackle all the problem, especially to face COVID-19. And I think and it will be very helpful if you can provide your research knowledge that is which is published already or yet to be published in future. And that knowledge can be taken with care and executed in our activities. And with these few words, and I like to give thanks to you again. And I am very grateful to you for inviting me. And thank you very much. And hope in future IEDCR will be the model of all scientific activities among all the research institutions, because this is the time, the present time is the crucial time to go on more research and research we should do. And you are doing that job, and the young doctors are very much energetic to involve themselves in research work. And I am very happy to know that they are going to take a higher degree from Bangabandhu Medical University in epidemiology. There is masters in epidemiology, MSc in epidemiology. It is good news. Whenever I came to know that some doctors are interested to have some that is pressure Bangla যদি বলি, it is deputation, right? Deputation, if they want to get deputation for higher study, then I, without thinking anything, I give the consent, because I am always in favor of higher study. I am always in favor of training, higher training and special training. Otherwise, we cannot enrich our institution, research centers, and all our academic that is institutions. So thank you very much. In future, we will we will work together for the sake of our nation, so that we can live with peace and happiness. Thank you all.
Thank you so much, sir, for your inspiring speech and appreciating the role of IDCR in the current pandemic situation. Ladies and gentlemen, now we have come to the end of today's closing ceremony. We request the chair of the ceremony, Professor Dr. Tahmina Shirin, to conclude the closing ceremony of the first Bangladesh Congress on Epidemiology and Public Health 2021.
I would like to thank all of you who were with us for two days, yesterday and today. Whole day you spend your time with the presenters who presented here with the panel discussion and all these things. And I wish great success of these the fellows and the young researchers who actually presented their research work, the posters and all these things. I wish your success in life. Thank you all for your patience hearing and stay with us 2 days. Thank you.
Thank you everyone for staying for the long 2 days with us. Thank you all.
আমার ল্যাপটপ কোথায়?